Good morning. I would like to thank Dr. Jane Fragoso Flores and Iris Fall, Michael Morris, and Susanna Zavala for the invitation and the organization of this event. Lymphoma is the most common hematological malignancy. It accounts for about 4% of all cancers and is the third most common malignancy in children. More than 80 subtypes are classified by World Health Organization. In this slide, are shown the main division according to the WHO classification. The first two are quite the totality. Most of lymphomas are B cell, about the 85%, and about the 15% are T cell lymphomas. Lymphoma may present with clinical symptoms such as fever or weight loss or mass effect syndromes. It may be localized in lymph nodes or can be extranodal localization, and the two conditions may coexist. Any organ can be an extranodal localization. Diagnosis and sedation is based on integration of molecular and cytogenetic data and imaging data. The most widely used imaging tools to study patients with lymphoma are computed tomography with contrast media, and in patients with glucose-avid lymphomas, positron emission tomography. Ultrasound plays a role in the evaluation in superficial nodes or in the evaluation of spleen, also with the contrast media, while MRI or MRI PET imaging is limited to in pediatrics or in suspected involvement of central nervous system. Fluorodeoxyglucose is the most common radiotracer used in PET imaging in oncology. In this slide are shown the FDG avidity of the main subtype of lymphomas, with the classic lymphoma, Hodgkin lymphoma, diffuse large B-cell lymphoma, and high-grade follicular lymphoma showing the higher FDG uptake. And the other subtype lymphomas can show a variable FDG avidity. For the staging of lymphoma, we have two main systems, the Ann Arbor staging system and the Lugano staging classification. In Ann Arbor staging system, we have to take in account the extent of the disease, for example, one or more nodes involved, the site above or below the diaphragm, and the extranodal localization. And also the presence of, with the Cotswold modification, we integrate it with the presence or absence of symptoms like fever or weight loss. Like in the Lugano staging classification that is routinely used, the classification of the tonsil, Valdayo ring, and the spleen are considered nodal tissue. Moreover, the extent of disease is determined by PET for glucose-avid lymphomas and by computed tomography in non-glucose-avid lymphoma. The Lugano system defines limited disease, the stage 1 and 2, and advanced disease for a stage 3 or 4. In all stage, we have to define the presence or absence of symptoms or the presence of contiguous extranodal disease that can be included in the same field of irradiation without have a change of the state. In the initial staging with PET-CT, we can detect the nodal station involved, the identification of extranodal involvement, the presence of bulky disease, and the presence also of incidental pathology that can affect the patient management. Moreover, it can also be useful to define the site for the biopsy with the less invasive intervention. In this slide, we see a male patient of 22 years old with an Hodgkin lymphoma showing a stage 2 limited disease by the Lugano classification, and with localization in nodes or in supraclavicular and mediastinal disease. While in this slide, we see a PET-CT scan of a male 21 years old patient with Hodgkin lymphoma with the presence of bulky disease. Is the dark image that you can see in the center of the thorax. And there is also the involvement of the supradiaphragmatic nodes like right axillary and left supraclavicular nodes. In this slide, this PET-CT is of a male patient, 64 years old, showing an advanced disease of non-Hodgkin lymphoma, with involvement of both supradiaphragmatic and subdiaphragmatic nodes, and the presence of gastric extranodal localization. This scan also addressed the site for biopsy in the left supraclavicular nodes. This is a scan of PET MRI scan that it was performed in a patient of suspected relapse of non-Hodgkin lymphoma. The arrows show the breast localization of the relapse. In this organ, over metabolic information derived by PET, MRI give more detailed morphological information and enhanced diagnostic accuracy of malignancy. In particular, the increased cellularity derived by diffusion weight image that you can see in the upper right picture. In indolent non-Hodgkin lymphoma, CT plays a central role in staging, but PET imaging can be a useful addition since are reported cases of upstaging and downstaging in this kind of lymphoma. Moreover, PET-CT scan is recommended in indolent non-Hodgkin lymphoma in the case of suspected transformation into a more aggressive disease. In Hodgkin lymphoma, bone marrow involvement is not very common and is range about 10 to 20%. PET in this lymphoma has a very high predictive negative value up of 95%. On the other hand, in non-Hodgkin lymphoma, bone marrow involvement is more common. Unlike Hodgkin lymphoma, positive bone marrow biopsies were found in more PET-CT negative scans. In this slide, I've shown the last guideline of European Society of Medical Oncology that is still in press. This guideline takes in account the 7 most frequent lymphomas. In the right panel, you see the grade of recommendation of this guideline. In diffuse large B-cell lymphoma, PET-CT is recommended as the standard imaging modality for baseline and treatment response assessment. The International Prognostic Index is a clinical tool that aids in predicting the prognosis and by giving 1 point for each of the risk factors present if they are present. In primary central nervous system lymphoma, PET-CT is mandatory to exclude extra central nervous system disease in other organs. In follicular lymphoma, PET-CT is mandatory in patients with limited disease before scheduled radiotherapy to confirm the localized disease. Moreover, is recommended for routine staging. In marginal zone lymphoma, PET-CT is recommended only when localized treatment is planned or as a guide of biopsy when clinical or laboratory data suggest transformation to high-grade lymphoma. In non-Hodgkin lymphoma, PET-CT is strongly recommended imaging modality, and bone marrow biopsy is recommended even in patients with negative PET-CT scan, even in front of a very high negative predictive value. In nodal peripheral T-cell lymphoma, PET-CT is the preferred imaging modality at diagnosis, at the interim evaluation, and also at the end of treatment. In this slide is shown the summary of the last recommendation of European Society of Oncologic Imaging in the assessment of treatment response. It divides lymphomas in 3 main categories according to glucose ability. In lymphomas with high glucose ability, the assessment of treatment response must be performed by PET-CT. While in lymphoma with variable glucose ability, assessment of treatment response have to be carried out by PET-CT only if the patient has a positive PET-CT scan at baseline. In non-avid glucose lymphomas, we have to use the CT. Always we have to use PET-CT in second and third group when an aggressive transformation is suspected. The Lugano classification recommends the Deauville 5-point scale for reporting FDG PET-CT scan. The Deauville scoring is a visual evaluation of PET scan that compares the target FDG uptake with the uptake in mediastinum or in liver. Deauville 5-point scale is recommended in all glucose-avid lymphomas and in some disease with variable glucose ability as cutaneous T-cell lymphomas or Waldenström macroglobulinemia. In this slide, I've shown the Lugano criteria to assess treatment response. Note that complete metabolic response can be achieved also in presence of residual mass. The Prolog consensus is an initiative of a response criteria in lymphoma working group that integrates the Lugano criteria with clinical data and data about the evaluation of spleen, liver, and nodal involvement. This evaluation regards in particular the Ig-Deauville score 4 or 5, giving an additional elements to categorize the patient as a no metabolic response or progressive metabolic disease. In this slide are shown a male patient of 41 years old with Hodgkin lymphoma. The interim PET-CT scan correctly predicts the complete remission at the end of therapy. The arrow shows a Deauville score 2 that's similar to the mediastinum. In this slide is shown a male patient of 64 years old with non-Hodgkin lymphoma. It's the same patient we have seen before. The interim PET-CT scan shows a moderate residual gastric activity and correctly predicts the complete remission at the end of in this other case is of a female or young patient of 26 years old. The interim scan see a regression of mediastinal localization, but we see a new localization in left submandibular. See the red arrow. So it's categorized like Deauville score 5 as a new lesion. After a change of therapy, we see a regression also in submandibular site, and correctly, the second interim predicts the complete remission at the end of therapy. In the interim PET-CT scan, evaluation is useful also measuring the variation of SUV, that's maximum standard uptake, between baseline and interim PET. This is particularly true in old patients more than 60 years old, and we can perform it at the first or the second interim scan. We have using FDG, we have also other diseases that can mimic PET-CT findings of lymphoma, like sarcoidosis, tuberculosis, histoplasmosis, mononucleosis, and Castleman disease. On the other hand, we can have findings that can make more difficult the evaluation of PET scan with interfering activity from salivary glands, kidney, bowel, or central nervous system, or the activation of brown fat. In the right side, you can see the activation of brown fat activation that can mimic the lymphoma pictures. Or in this case, that we have an activation of bone marrow that make more difficult the evaluation of bone. In this slide, in the left, is summarized the potential targets of PET radiotracer. In the right side, you see the more big circle means that there are more studies about some specific target. This is a field in development, and one of the most promising new radiotracer is the Pentix4 that target the chemokine receptor 4. The chemokine receptor 4 is involved in the spread of cancer cell and in the communication between cells. With another new tracer that's under development is those tracers that that target the CD antigens, like the rituximab, that's a zirconium market new radiotracer that label the CD20 receptor. This is it has a very high implication, therapeutic implication, since rituximab target the CD20 antigen. So we can monitor the patient if it is possible to use this monoclonal antibody, or to explain when a patient doesn't respond. This it was the last slide I show, so I thank you very much for your attention.